Normally when delivering oxygen you lay the oxygen tank down so it is safer. However, for this demonstration I will not be doing that. Before we can deliver oxygen we must apply a regulator, and we need to check the Bodox seal to make sure that there is no damage. This one's good, so I'm just going to apply the regulator now. You slot it in and you tighten it with quarter turns until it is finger tight. When the regulator is applied, you turn on the valve to check how much oxygen's in there. This is full, so it's good to be used. And you have to check the flow rates to make sure that they're all flowing differently. After you've done this, you are ready to attach a mask or tube. There are a lot of different types of masks. Both the acute mask and nebulizer masks deliver 60% oxygen at a flow rate of 6 to 8 litres per minute. The non-rebreather mask delivers 90% oxygen at a flow rate of 10 litres per minute, and the BVM delivers 98% oxygen at a flow rate of 10 to 15 litres per minute. However, for this demonstration I'll be using nasal prongs, which deliver 30% oxygen at a flow rate of 2 to 4 litres per minute. So I'm going to apply them. I'm going to turn the flow rate on to 3 litres per minute, and this is now ready to be placed onto a patient. When done with using the oxygen, you can turn off the flow rate and detach the tubes. You then have to turn off the valve and flush out the regulator. This gets rid of any remaining oxygen that's in the regulator. This is now ready to be taken off. Now I'm going to demonstrate how to use the BVM, which stands for bag valve mask. So the first thing you've got to do is you've got to check to see if the valves are leaking. So you check the backflow. Do this by covering up the mask end, squeezing, and there's no leaking, so that's good. I'm just going to assemble it by attaching the reservoir and the mask itself, and I'm going to attach it to an oxygen tank and put the oxygen tank onto a flow rate between 10 and 15. So I'm just going to put it on a flow rate of 12, and you see if the reservoir fills up. If it doesn't, then it might be leaking and you should replace it. Okay. Before ventilating the patient, I'm going to insert an OPA. To do this, you have to measure it up first. It's the right size OPA, and insert it. Make sure he accepts it. It's okay. And then we can go to ventilate our patient. When ventilating our patient, we do the head tilt, chin lift, and the C-grip over the face to ensure a good seal, and then ventilate every 5 to 8 seconds, checking for chest rise. That's good. If we are suspecting gastroinflation, we can get a secondary offer to provide cricoid pressure when ventilating, which would block off the esophagus so air doesn't enter the gastric tract.
So today we're going to use the suction device on our patient here. You use the suction device to clear the airways from vomit, phlegm, blood. But before we can start suction, we must make sure that the suction device is working properly. So to do this, you seclude the airway and turn it on and watch to see if it exceeds 350 millimeters of mercury. So I'll just do this now. Yeah, so we're sweet. If it does this, then it means that the air tubing is airtight and it has no leaks in it. So before we can start suctioning as well, we must turn our patient laterally into the recovery position. And what I'm going to do is I'm going to put the rigid catheter down into his oropharynx no further than I can see, and place my thumb over top of the holes so that the suction can start, and you do circular motions on the way out for no longer than 10 seconds. So I'll just do this now. As Excessive sucking can cause hypoxia, which can lead to tachycardia. Also, you must be mindful with using a rigid catheter not to cause damage to the oropharynx or mucosa or teeth. Other complications could be induced vomiting. And if you're in a moving vehicle, the rigid catheter cannot be used.
Now I'm going to demonstrate how to use the OPA. The OPA is used to maintain the airway. It does this by holding the back of the tongue off the oropharynx so that it does not block the airway. Indications for the OPA is if the patient has a GCS of less than 8 or a verbal GCS of 2 or less. Before inserting an OPA, you have to measure it up. You do this by placing it next to the edge of the mouth and making sure the other end reaches the angle of the mandible. If the OPA was too small, it could push the tongue, blocking the airway, and if the OPA was too large, it can cause choking. This is the correctly sized OPA. I'm now going to insert the OPA by putting it towards the roof of the mouth, being careful trying not to damage the patient's mouth. When it reaches halfway, rotate it 180 degrees to insert it the rest of the way. After doing this, you've got to check to make sure that the patient accepts the OPA. Contraindications for the OPA include a clenched jaw or oral trauma, as you will not be able to get the OPA into the mouth. Other complications include induced vomiting or induced gagging, and with the rigid structure of the OPA, it could cause damage to the mouth, teeth, or other areas of the oropharynx. Now I'm going to demonstrate how to use an NPA. Like the OPA, the NPA is used to maintain the airway when giving ventilations. However, the NPA can be used if the patient has a higher GCS. It is indicated if the patient has oral trauma or a clenched jaw, or if the patient does not accept the OPA. Before inserting the NPA, it is important to measure it again. You do this by placing it next to the nostril and making sure the other end reaches down to by the angle of the mandible. Before inserting it, it is important to lube it up. Just doing that now. This is so it inserts easier. And you also choose the larger nostril, which is normally the right nostril, but it's important to check. You then insert it 90 degrees to the patient's base, and upon resistance, rotating the NPA. Contraindications to the NPA include a base of skull fracture or a nasal obstruction. Other complications can be nasal bleeding or nasal polyps. Now I'm going to demonstrate the LifePak 15. So the first thing I'm going to do is turn it on. While it turns on, it's going to go straight to the AED mode, but we can just
push ammo.
We can change it to manual mode by selecting Energy Select, which put on 50 joules. The next thing we're going to do is an operational check. So we put it on test user, and it's going to run some stuff. And while this happens, we can check the batteries. So that one battery is on 3 bars, the other one's on 4 bars. We can also check this around the back. Lift this, pressing the button. That one's on 4, this one's on 3. Sounds like our operational check's done. Sweet. And it's passed. Check the date and check the time. It's passed. It's currently in a simulation, and we can change the leads by pressing the lead button. Go down to the 1, 2, 3 leads. We can change the amplitude by going size. We can make it smaller or larger. Let's make it larger, put it on 2. Let's make it larger. We can also change the volume of the QRS by selecting the heart rate. And there's the beat. That's good. And we'll go back. We also have to run a AED check. So I'm going to unplug it from the simulator and plug it into the AED. And to do this, we just click charge. It's charging up. When it's charged, we can either select the shock button or the disarm button. I'm going to deliver the shock. Shock delivered, sweet. Other things that this has is a carbon dioxide meter. We plug this in up here and rotate it clockwise. It's come up, and this just plugs into where it gets attached to a bag valve respirator. It's also got a non-invasive blood pressure cuff, which you can test by pressing the NIBP button, and a pulse oximeter, which attaches to the finger of the patient, which will read their pulse and SpO2 levels. The final thing we have to do is check the paper is fine. There's obviously lots in there. If it was running low, we could chuck some, and we've got spares in the back that we can put in it too. Now I'm going to demonstrate how to take vital signs. The vital signs I'll be taking is the pulse, the respiration assessment, and blood pressure. The first one I'll take is the pulse. So normal pulses range between 60 and 100 beats per minute, and when checking a pulse, you are checking the strength and regularity of the heartbeat. When taking a pulse, you can take the radial, brachial, carotid, femoral, and pedal pulses. However, for the purposes of this demonstration, I'll just be taking the radial pulse. This can be found laterally on the wrist, and before taking a pulse, you must gain consent of your patient. So, sir, can I just take your pulse?
Sure.
Right now? Thank you. And can I just put it across your chest like this?
Sure.
You do this for 30 seconds, and you multiply it afterwards. I'm just going to do this now.
Yep.
So, I was timing on my cell phone, and I was checking his pulse rate for 15 seconds of the 30 seconds, which came to a pulse of 20, which multiplied by 4 gets a heart rate of 80 beats per minute, which is well within the normal ranges of 60 to 100. And for the second set of 15 seconds within my 30-second assessment, I was actually checking his respiration. That's why I put his arm across his chest. I didn't tell my patient this because it could affect the results. And the normal respiration rate is between 12 and 20 breaths per minute. My patient had breathed 4 times within the 15-second assessment. You multiply this by 4 and it comes to a respiration rate of 16 breaths per minute. To get the volume and clarity of my patient's breathing, we must auscultate his chest. So this means to listen to the lobes of his lungs, both posteriorly and anteriorly on both lungs. However, for the purposes of this demonstration, I'll only be doing it on one lung. Before auscultating, you must gain consent of your patient. So, sir, can I just listen to the lungs? Your lungs right now? Okay, so I'm just going to come in down the front of your shirt, just like this. And can you breathe in for me? And breathe out. And breathe in. Breathe out. And can I just come up your shirt? Thank you. Breathe in. And breathe out. And it's going to come, can you lean forward, just come out the back here. Breathe in. And breathe out. And last one is just down the back. Breathe in. And breathe out. So when doing this, you're listening for any stridor on inspiration, as well as wheeze on expiration, or any crackling noises which could indicate fluid in the lungs. For a full respiration assessment, you could also take into consideration the position of the patient or the amount of words they use per breath, or you could gain a SpO2 reading. Now I'm going to demonstrate how to take a blood pressure. Before I can do anything, I must gain consent. So am I able to take a blood pressure?
Sure.
And before taking his blood pressure, I'm going to remove any restrictive clothing, which could be watches or bracelets, and I'm going to roll up his sleeve so I can apply the cuff. I'm going to measure the cuff before applying it, using the range, just measuring his bicep, and this is the correct size cuff for him. I'm now going to find his brachial pulse, which I have now located, and I'm going to apply the blood cuff. Where it says artery is where I found the pulse. I'm applying it on. Just going to put this up here so I can read it. and put my stethoscope again where I found his pulse. You got to support the patient's arm as it's got to be straight. I'm now going to blow up the blood cuff until it's past 140 and then release the valve until I can begin to hear his heart rate. Okay, I can hear his heart rate at about 120 millimeters of mercury. This is his systolic pressure, and if I keep releasing the valve, I can no longer hear his heart rate at 70 millimeters of mercury. This is his diastolic blood pressure. Just going to completely release that. Normal blood pressure ranges between 120 systolic and 80 diastolic, but this is plus or minus 10 millimeters of mercury.
So with hemorrhage control, you've got to make sure that you're wearing your personal protective equipment because you're dealing with someone else's blood. And the first thing we want to do is we want to expose the wound. So I'm just going to do that now. And he's just bleeding on his forearm here. We're going to try clean the wound with saline. When we apply a non-adhesive bandage, we want to moisten the bandage so that the bandage does not stick to the wound, so that when people take it off in A&E, half the wound doesn't come with it. So we're just going to put this here, and we're going to add direct pressure onto the bleed. We use a crepe bandage in order to apply more direct pressure onto the wound as well. Smaller bandages are used because they can offer more direct pressure than larger bandages. Also, adding twists to the bandage is another method that can be used to add direct pressure to the wound as well. So I'm just going to do this now, adding twists. Okay, and if the bleeding continues, we just sit and we watch to see if the bleeding stops, but if it continues we can always add another dressing over top of this one, or elevate the arm so it also reduces the bleeding. If the bleeding becomes catastrophic, the use of a tourniquet is required. We just place it over the arm 10 centimeters proximal to the wound. And with arms, we use the single D loop on the tourniquet, whereas if it was applied to the leg, we'd be using the double D loop. Applying it now, 10 centimeters proximal to the wound, and we tighten it until we no longer feel, sorry, I wasn't on properly, but we just apply it, we start tightening it until we no longer feel a radial pulse or the bleeding of the wound stops, and we note the time taken, just write the time on the tourniquet of which it was applied, and still, if bleeding still does not stop, we can always apply a second tourniquet proximal to the last tourniquet applied.
Now I'm going to explain how to use the C-collar. So a C-collar is indicated if our patient has a neurological deficit. This means that upon palpation there is numbness or tingling in their limbs, or there is no feeling at all, or perhaps they won't be able to move their limbs. It is also indicated if our patient is intoxicated, they have a distracting injury, if they have an altered level of consciousness, or there is midline spinal tenderness upon palpation of the neck. Before applying a C-collar, we must first gain consent. However, if our patient is unconscious, then we assume consent. So now I'm going to get my secondary officer to supply support to the head while I measure up the patient and make sure that the C-collar is a fit. I'm just going to adjust it because it's currently too small. and then we are ready to apply. To apply, I'm going to insert it underneath the neck and bring the top end round, making sure that it's not caught on any jewellery or anything that could put pressure into the patient, which could hurt them. After applying, it is good to keep the secondary officer to support the head and to check to see if they can still breathe and that you haven't blocked their airway. Now I'm going to demonstrate how to do fracture management. So the first thing we have to do is we have to expose the fracture. So I'm just going to roll up his hands. Have to do it on both so we can compare with the other leg. Okay, so to determine whether it's a fracture or not, we use the plastic acronym. So that stands for pain, loss of function, unnatural movement, shortening, deformities, irregularities, swelling, crepitus, and shock. So after this, we use this to determine if it's fracture. It's a fracture of the tibia and fibula. So we're going to assess the cardiovascular and neurological integrity. So first the cardiovascular, check capillary riffle on both feet to compare. Also the temperature, the pedal pulse, and see if the colour is the same. So it's fine. We've got to check the neurological integrity. So to do this, I'm going to ask the patient if he can move his toes. Can you move your toes, sir?
Yeah.
Thank you. Can you feel me touching you right now?
Yes, I can.
Sweet. So he's got sensation and he's got motor movement, so it's okay. The next thing I'm going to do is I'm going to ask, what's your pain, sir?
For 7.
About 7. So we have to give him pain relief in the form of analgesia. Today I'm going to be giving Internox. So you've got to check the date. Right, April 2017. Can you check this for me? Ask my bystander, secondary operator to check as well. Yep, sweet. So I'll check it one more time. Yep, April 2017. Okay. So I have to ask the patient if he's got any contraindications before I can give it. So have you been scuba diving the last 24 hours, sir?
No.
Have you got any chest pain or difficulty breathing?
No.
And have you been able to go number 2s?
Yep.
Sweet. So we don't suspect pneumothorax, or a bowel obstruction, and he can obviously obey commands. You haven't got any allergies
No.
that you know of? Sweet. So this is a self-administering drug, so just suck on that, sir. Do you want to come over here and help me support his leg?
Sure.
So take 5 or 6 deep breaths and then you'll start to feel something. So today we're using a box splint. We've got a towel in there for extra support and comfort for the patient. What's your pain like now, sir?
About a 3.
Okay, sweet. So that we can see that the pain relief's working, I'm just going to slip this under here. Okay, and we're using triangular bandages to support the fracture. So we're going to have to tie them above and below the fracture, the side of the fracture, so that we can, so it immobilizes the fracture. We don't want to tighten it too much that it cuts off the blood circulation. Can you lift up his leg, please? Thank you. Just going to go figure 8 around the foot, tying it nice and tight to support it. And one more just in the middle. Lift up. Is that alright, sir?
That feels good.
Okay. After doing this, I'm going to reassess his neurological and cardiovascular integrity by running the same test as I did earlier. So now I'm going to demonstrate how to do CPR. So we've been called out to a patient who's had a cardiac arrest. So before we can approach, we've got to make sure that there's no dangers. So we're wearing our personal protective equipment, which is our gloves and our glasses. We've got to scan the environment to make sure that there's no dangers here either. So we're currently in a classroom, so we've got to be mindful of bystanders. There might be bystanders who can come in who could be emotionally distressed, and which could be dangerous, and just got to be mindful of that. We could also use bystanders to get a patient history. So excuse me, sir, do you know what's happened here?
Nope.
You don't know this man's name or anything?
Nope.
Alright, so first we'll get a response. Sir, can you hear me? Sir, can you hear me? So there's no response, so I'm going to get my secondary officer to call for an R50 or an R49. Well, I'm going to check his breathing, opening up his airway, trying to see if I can feel any air, looking for chest rise. You do this for 10 seconds. There's nothing. Get on his chest. While he does that, I'm going to set up the AED. following the instructions on the pads. It goes down there. This one goes here, just working around my partner. I'll turn it on. While it turns on, we can get the
Analyzing
BVM
heart rhythm.
ready.
Do not touch
Plugging
the
it
patient.
into the oxygen tank. Turning the tank on.
Shock advised.
Getting the flow rate going.
Charging. Stay
Flow rate of
clear
10.
of patient.
Right, let's get ready.
Deliver shock.
Stay
now.
clear.
Press the shock delivered.
Shock delivered.
Pause.
Right, get back on his
Start
chest, man.
CPR.
So he's gonna do, from now on, I'm gonna maintain his airway by putting in an OPA. Putting it in, inserting it all the way.
25, 26, 27, 28, 29, 30.
So he's doing a ratio of
Chest
3
rise.
to 2.
Chest rise.
And when we ventilate, we're doing the head tilt chin lift. Currently he's doing compressions at a rate of 100 compressions a minute, pushing down a third of the chest.
30.
Chest rise.
Chest rise.
Alright, next time, man, can you add direct cricoid pressure? This is going to prevent any gastroinflation. If any air is not going into the lungs, it could go into the gastric region.
26, 27, 28, 29, 30.
Chest
Chest
rise.
rise.
Thank
Chest
you.
rise.
So we've got a suction unit here too, so if our patient starts vomiting or anything, we can roll them over into the recovery position and suck out any unwanted fluids.
30.
Cricoid pressure. Chest rise.
Chest rise.
Cool. And when this goes off and is ready to go again, we're going to swap positions and I'll start CPR and he will start ventilations.
26, 27, 28, 29, 30. Chest rise. Chest rise.
Your compressions are good, man. Good timing, good timing. Chest rise.
Chest rise.
Chest rise. Right,
Stop
swap.
CPR. Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. No shock advised. Pause.
Right, I'm going to get back onto his chest.
If needed, start CPR.
Chest rise. Chest rise.
So if our patient has a sudden return of spontaneous circulation, also known as ROSC, then we would no longer need to do any more compressions. However, if our patient wasn't breathing by themselves, we'd have to keep going with ventilation. So can you ventilate him?
Yep.
Ventilate him every 5 to 8 seconds, man. And also we could, if he vomits, we could again put him in the recovery position. If he starts breathing by himself, again we can just put him in the recovery position and get ready to transport to hospital.